An educational pamphlet about orthodontic-prosthodontic collaboration. Orthodontic-prosthodontic collaboration. Introduction. Adjunctive orthodontic treatment involves tooth movement that enhances the success of other dental procedures necessary for the control of disease and restoration of function. If existing tooth positions make it impossible or difficult to insert dental restorations, and if there is a possibility that such restorations will produce a pathologic situation unless tooth positions are altered, orthodontic treatment should become part of the treatment plan. In this collaboration, the specialists involved are an orthodontist and a prosthodontist. An orthodontist is a dentist trained to diagnose, prevent, and treat teeth and jaw irregularities, while a prosthodontist is a dentist who specializes in treating complex dental and facial matters, including the restoration and replacement of missing or damaged teeth with artificial devices. Patient evaluation. An organized and coordinated approach to diagnosis and treatment planning is needed for a successful result. The patient's need for periodontal, orthodontic, prosthodontic, and endodontic treatment and surgery should be evaluated carefully. In order to obtain this information, cephalometric, panoramic, or periapical radiographs, study casts, and intraoral extraoral pictures should be taken. Besides these patient records, a clinical examination should be performed. Also, caries elimination, endodontic therapy, and extraction of incurable teeth should be carried out prior to orthodontic treatment. Treatment objectives. Malposed teeth should be moved orthodontically in order to make them better abutments for prosthodontic restorations. Such procedures include closing of diastemas, making teeth upright or parallel, gaining of sufficient pontic space, correction of anterior or posterior crossbite, and rotation, intrusion, or extrusion of teeth. Properly aligned teeth are able to withstand functional and parafunctional forces more readily than malposed teeth. Attempts made to correct malposed teeth using prosthesis alone will fail both aesthetically and periodontally. In the picture, Figure 1A shows tipping and drifting of adjacent teeth and supereruption of unopposed teeth as a result of a missing lower molar. Figure 1B shows creation of pontic space by uprighting the tipped molars and improvement of the bone contour.
When molars are missing, it is common for the adjacent teeth to gradually tip into the extraction site over time. This tipping can lead to a variety of dental issues, making it crucial to consider uprighting or paralleling these tipped teeth before proceeding with prosthetic restoration. There are numerous advantages to this approach as outlined below. First is the elimination of periodontal problems which occur in the presence of tipped molars. Next is the uprighting of tipped teeth, which will improve the distribution of occlusal forces and the teeth may optimally withstand these forces. Next is the improvement of crown root ratios of periodontally involved molars. Next is the provision of the shortest possible span, thus reducing flexing of bridgework and reducing undesirable forces transmitted to the abutment teeth. Next is the prevention of pulp exposure during the preparation of tipped teeth. And lastly, paths of bridgework will be parallel to the long axis of the roots. Should restorations be performed without uprighting or paralleling the teeth, compensations will be necessary in terms of crown height and contour to avoid potential periodontal damage. Once these goals are achieved, the dentition becomes more amenable to oral hygiene techniques, specifically improving the long-term prognosis. As adult orthodontics have become more socially accepted, adults have been accepting orthodontic therapy more readily. Patient preparation and education should involve the explanation of why orthodontic treatment is needed and information about the minor annoyances involved in orthodontic therapy. Physiologically, no change induced by growth of the adult patient is expected. Vascularity and cell structure decrease with age, and thus, slower tooth movement is gained by orthodontic force application. Pathologic changes and hormonal and systemic problems may limit treatment objectives or alter the course of treatment. After the completion of orthodontic treatment, it is customary for patients to wear retainers until final restorations are placed. Fixed orthodontic appliances can also serve passively as retainers before prosthetic replacement. Now we will move on to the sample cases. Sample case number 1 is about a 21-year-old woman who was found to have congenital absence of the lower third molars and the bilateral first molars were missing. After routine diagnostic investigation, it was decided to upright the second molars distally while moving the premolars mesially. Fixed orthodontic appliances were inserted as shown in figures 3A and 3B, and molar uprighting mechanics were utilized. A retainer was then placed immediately following the removal of orthodontic appliances. Figures 4A and 4B show the fixed bridgework in the mouth. For sample case number 2, we have a 22-year-old woman who was referred to our clinic by her dentist. Her lower left second premolar was missing and the first and second molars were tipped mesially, creating a dental class 3 relationship on the left side. After evaluating the case, it was decided to distally upright the first and second molars and thus create enough pontic space for a bridgework. The lower left third molar was extracted in order to enhance distal tooth movement. Figure 6 shows the orthodontic treatment mechanics used to distally upright the first and second molars simultaneously. And after uprighting the molars and gaining enough pontic space, the fixed appliances were used passively for retention. Figure 7 shows the final metal ceramic bridgework. Sample case number 3 involves a 25-year-old man that had congenitally absent upper lateral incisors. The upper central incisors had drifted laterally, creating a 10 mm midline diastema. Cephalometric evaluation showed a mild class 2 tendency and some labial flaring of the lower anterior teeth. Since the cortical bone between the central incisors was present, it was decided to move these teeth into the lateral incisor positions while bringing the upper canines into a class 1 relationship. Meanwhile, the lower anteriors were slightly retracted to bring them into more upright position and to close the diastemas. Figure 9A shows fixed appliances kept in place for retention and acrylic central incisors ligated to the arch wire in order to keep the space gained and to obtain a better smile at this point. A 6-unit bridgework was constructed, extending to the canines, and figure 10 shows the final metal ceramic restorations in place. Summary and conclusions. Orthodontic-prosthodontic collaboration enhances the results of restorative treatment in adult patients. Restoration of malposed teeth using prosthesis alone will fail both aesthetically and functionally. Orthodontic problems such as spacing, crowding, malposed, rotated and tipped teeth will compromise the final restoration if left untreated. Thus, it requires orthodontic correction prior to prosthodontic treatment. Correction of axial inclination of teeth helps in preventing pulpal exposure during preparation and in improving the periodontal status of the involved teeth. Cooperation between the orthodontist and the prosthodontist will ensure favorable and optimal treatment results for the patient. Thank you for listening.